like people with significant mental health issues have increased risk of developing diabetes. So probable risk factor which has been proposed are maybe unhealthy lifestyle that includes diet high in processed sugars or inadequate quality of sleep, poor resources, or chronic stress response associated in mental health disorder, which can lead to diabetes. So, as we have discussed, there is a two-way communication between depression and diabetes. Uh, there is a common link between type 2 diabetes and depression. So, 10 to 30% of people with diabetes have depression, but depression is highly underdetected and quite treatable. So, coming to the statistics part, this data I have taken from Psychiatry Journal. So, 1 year prevalence of depressive episode in diabetic population was as high as 9.3% as compared to 3.2% in people without diabetes. Uh, as we have already discussed, 15 to 30% of diabetic population can have depression, in which 15 up to 15% have major depression, and 9 to 16% can have other forms of depression. This depression is associated with all stages of diabetes, right from pre-diabetes to the diabetic complications and mortality. The common mechanisms, plausible mechanism which has been proposed to explain the link between depression and diabetes are divided into two categories. These are psychological process and biological process. So in the psychological process, we have stress, like diabetes specific distress or other form of stress, depression, uncontrolled satiety or problems, abnormal satiety or impulse control disorders. While in biological process, there can be mechanism, could be abnormal activation of hypothalamic pituitary axis, innate inflammation, autonomic nervous system hyperactivity, and so on. So there could be common origin for both depression and type 2 diabetes, which led to higher innate inflammation. This higher degree of inflammation is associated both with insulin resistance as well as depression. The cause of increased innate inflammation could be fetal nutrition, lifestyle choices, social adversity, or genomic diversity. So, both depression and diabetes are associated with high risk for all cause of dementia. So, in diabetic people, they have hazard ratio of 1.31 for developing dementia as compared to the normal population. After 10 year of diagnosis of diabetes, this long-term hazard ratio increased to 42%. So people with diabetes, after 10 years of diagnosis of diabetes, they have 42% higher chances of developing dementia as compared to their normal counterparts. So this is a table which has compared the hazard ratio for dementia in normal population, in diabetic population, in depressed population, and in comorbid population having both diabetes as well as depression. So it is clearly seen that hazard ratio is highest in the comorbid category, which includes both diabetes as well as depression. So diabetes and depression, as we have already discussed, it's a bidirectional relationship. 10 to 30% of diabetic people will develop clinical depression, and comorbid depression and diabetes have 2.7 fold increased risk for dementia. So to study this link, many prospective studies have been conducted, which have shown the bidirectional relationship, such as baseline depression will have higher, people having depression are having higher incident of type 2 diabetes, and the other way around, people having diabetes are having increased risk of developing depression. So history of depression may confer an increased risk for later developing diabetes, and this relation is an independent risk factor for the disease. Interval between diagnosis and depression and Alzheimer's disease was positively uh, it is associated with increased risk of developing Alzheimer's disease. And the meta-analytic evaluation resulted in pool's odd ratio of 2.03. So, but this depression, as I already told, that it is highly unrecognized. Why there is obstacle to recognize depression in medically ill people? There are multiple reasons. Like, medical symptoms mask depressive symptoms. People often attribute their weakness, low weight, low appetite due to the medical condition. Serious medical illness make depression acceptable as a normal reaction. Vague presentation of depression in medical setting, and 1 in 5 primary care visits for new symptoms with no identified cause could be there. So many times people come to OPD and they say ki I am feeling very weak and appetite is low and the lifestyle has markedly changed, and but we attribute it to maybe your blood sugar is not controlled, let's control your blood sugar and then we'll see. So it is important to timely diagnose and management depression in such people. So in this pie chart, we can see that this is taken from a psychiatry journal from 1998. So in 372 people of diabetic, 47 were having major depressive symptoms, but out of them only 8 were recognized, only 2% were diagnosed. Uh, 13 uh, rest 39 people were undiagnosed. The major reason of late diagnosis of depressed people could be the depressed patients presents the symptoms as primarily somatic symptoms. So these somatic symptoms could be anything, right from cardiological to neurological to gastrointestinal to pulmonary symptoms. So people often attribute these symptoms as some medical symptoms or physical symptoms rather than the mental symptoms. So, does depression predisposes to diabetes? Answer is yes. Premorbid depression have 37 to 100% increased risk of developing type 2 diabetes. And in type 2, as far as type 2 diabetes is concerned, the mean age of onset of depression typically predates the age of onset of type 2 diabetes. While in type 1 diabetes, which is a early onset disease, we know it predates the onset of depression. So multiple somatic symptoms, they are more common in diabetic people having comorbid depression, like cold hand, numbness in hands, pain in hands or feet, blood vision, daytime sleepiness. These symptoms are common in comorbid population. So depression is a contributor to both diabetic morbidity as well as mortality. The various reasons are poor glycemic control. Depressed individuals, they are more likely to uh, not follow the dietary recommendation or medical management. There is an increased risk of diabetes related complications such as retinopathy, nephropathy, macrovascular complication. Coronary heart disease incidence is also more rapid in depressed women, and the quality of life is low. So the same slide continued. So there is a depression is having a worse outcome in the diabetic population, and also the relapse rate is 5 times higher in depressed individual in non-diabetic when not on any prophylactic treatment. So depression, the relapse rate is higher in diabetic population as compared to the non-diabetic population. Mortality, as depression also worsens the mortality rate in diabetic population. So in this diagram we can see that comorbid population having both diabetes as well as depression is having highest hazard ratio for all cause mortality. So depression and diabetes is a vicious circle. People having depression, they have lack of motivation, they have no motivation for the management of diabetes, which led to poor management of diabetes, which led to high blood sugar levels, greater fatigue and lethargy, worsens mood and increase depression. So it's a vicious circle. Coming to the management part from our side, we'll discuss the psychiatric part of management with Dr. Amrit in the next session of the discussion. So from our side, what can be done to reduce the development of dementia and diabetes? Uh, Appropriate blood pressure control, better glycemic control with avoidance of hypoglycemia. Statins for the dyslipidemia part, treatment of depression at timely diagnosis and management of depression, and emphasis on cognitive function assessment. Simple questionnaires can be questionnaire forms can be given to patients on every visit to know the mental status of the patient. So does treatment of diabetes make a difference? So there was a study, nurses health study, which was conducted in nurses between 70 to 81 years of age, in which diabetic women are compared to women without diabetes, but diabetic women were treated with OHA and the glycemic targets were achieved. So there was no significant difference between the development of dementia in the both groups. So as far as diabetes is properly controlled, the risk of developing dementia as well as depression is significantly less. Women with type 2 diabetes have 30% greater odds of poor cognitive function than those without diabetes, with a 50% increase after 15 years of diabetes. In the management of glycemic management, control of hypoglycemia is also important, because repeated episodes of hypoglycemia is an independent risk factor for development of dementia. So in this table we can see the number of hypoglycemic episodes are associated with increased risk of developing dementia. In people having 3 or more episodes, they have higher risk of developing dementia as compared to people having less hypoglycemic events. So avoidance of hypoglycemia is equally important as glycemic management. So should we review glycemic targets? Answer would be yes. Normally as we know that we maintain HbA1c level below 7% in the normal diabetic people, but we should review the glycemic targets to higher levels if there is significant cognitive impairment, if there is hypoglycemic unawareness, history of falls is there, evidence of advanced or poorly controlled cardiovascular or microvascular complication is there, life expectancy is less than 3 years, or palliative care is being given to the patient, then HbA1c target should be relaxed, and focus should be on the avoidance of hypoglycemia. So it's a data taken from a retrospective cohort study of approximately 288,000 medical beneficiary, and out of them 44,000 have comorbid dementia. So dementia reduces the likelihood that individual with diabetes will receive recommended annual monitoring for diabetes. So people having dementia, they have less monitoring, less treatment, and high risk of developing morbidity as well as mortality due to diabetes. So this brings me towards the end of my session, and now we'll discuss the management part, diagnosis and management part with Dr. Amrit in our next session. Over to you, sir.
Thank you, Dr. Ankita.
Yeah.
Short, sweet, and absolutely wonderful. So you've set the ball on the court. I'll be a little faster because I have a lot of things to share. Maybe I'll be skipping through certain things. So yeah. So my topic is diabetes and its reflection on mental health. This is absolutely a combination presentation between endocrinologist and a psychiatrist, and it is very, very important. Maybe our slides have a lot of commonality, and that is very, very important, because when we are going towards a common target, some of the paths will be common. And if you look at diabetes and mental illness, maybe around 45% of the psychological problems or mental illness in diabetics it never comes on the open, and that is why this is one of the important topics to be discussed, because however hard madam tries to take care of the, she'll get angry that somebody is not taking proper glycemic control, somebody is not taking medications, somebody is eating more sweets, somebody is not doing exercise. But it might be that there might be underlying depression, somebody is not motivated to take, and it leads to a lot of, physician burnout also when we have patients who are not compliant. But again, it leads to a lot of patient burnout also when the patient thinks that the physician is not understanding why I'm not able to do all these things, or whatever madam is telling or whatever sir is telling, I'm not able to take care. So these are areas where the physicians have to be aware of, and the patients have to be also aware of certain things, that these things might happen in somebody who has diabetes. So I'll start my presentation. So I'll only tell one quote. Sir Henry Maudsley. Maudsley is one of the fathers of psychiatry. We have a Maudsley guideline where we discuss about how to treat patients. He commented that diabetes is a disease which often shows itself in families in which insanity prevails. So the correlation and the comorbidity between diabetes and psychological issues has been since times immemorial. So in 1879, he actually commented on that. So link between diabetes and psychiatry, it might present as a co-occurring independent condition with no apparent direct connection. It might be just two diseases in a same individual. Diabetes as a risk factor for development of psychiatric disorders as a risk factors for emergence of diabetes. So it might be this way or that way. Overlapping clinical presentation of diabetes and psychiatric disorders, interaction of medications, which is very, very important aspect, because people on diabetes need medications, people having psychological issues need medications, and the interactions might sometimes be very, very bad. And impaired treatment adherence, that is what I was talking to about, people who have some endocrinological issues in terms of diabetes, being depressed, not adhering to what treatment is being given to them. So what it leads to basically, if both of them occur together, impaired quality of life, increased cost of care, even twofold or even higher. Somebody is not taking proper care of glycemic care, and you need to increase the insulin or maybe the anti-diabetic medications. Poor treatment adherence, poor glycemic control, increased emergency room visits due to diabetic ketoacidosis is another big thing that we come across, and higher frequency of hospitalization and higher rate of absenteeism in follow-ups. So this is how depression negatively affects glycemic control. So coming to diabetes and dementia, madam has described a lot about these things. So 20% of patients found to have undetected cognitive impairment at baseline. Look at diabetic patients, and if you look at the baseline, cognitive function, if you look at the DSST, which is a pen and paper test, so even at 40 months there was no difference. So screening is very important. Like you screen for retinopathy, you screen for neuropathy, you screen for microalbuminuria, you screen for peripheral arterial or CV disease if symptomatic. So cognitive impairment or dementia is often undiagnosed because of people feel that there's no benefit of early diagnosis. But I would always suggest that if you just ask 4 or 5 questions and get to know that there is some cognitive impairment, you can intervene fast and the benefits might be phenomenal. So what are the benefits of timely detection? It maximizes function, so it gives greater independence to your client. Early treatment, early care can be instituted. Leads to improved healthcare, quality of life significantly improves. There's better clinical management, and finally, it leads to reduced healthcare costs and career burden. So, diagnosing psychiatric disorders among patients. So, up to 45% of the cases of mental disorder and severe psychological disorders go undetected. Among anxiety disorders, generalized anxiety disorder consistently increases the risk. There is increased risk. And they are confounders of panic attacks and hypoglycemia. If you look at hypoglycemia, it is one of the most life-threatening complications of diabetes and diabetes treatment. And many times panic attacks mimic a hypoglycemic attack. Like I'll tell you, day before yesterday, I got an emergency call. One of my patients who is a schizophrenic, who is diabetic. He had a sudden seizure attack in Khurda. Patient was immediately moved to the district headquarter hospital. I told them the patient was also having epilepsy. I called them up and told them, please check the fasting blood glucose, give him a dextrose, give him lorazepam. And when they found the fasting blood sugar was 24. So the patient was psychotic. Patient had taken insulin but had not taken food because of some anger issues at home. And he was found on the street having a seizure attack with a fasting blood of 24 or a random blood sugar of 24. Immediately I brought him to high tech, hospitalized. 24 hours he was improved. So that is what hypoglycemia can do. And many times panic attacks almost mimic a hypoglycemic attack, or a hypoglycemic attack mimic a panic attack. So understanding the difference between both is very, very important. So diagnosing diabetes in patients suffering from psychiatric illness, we see a lot of comorbidity between schizophrenia, maybe due to the illness per se, maybe because of the treatment. So psychosis itself increases the risk of diabetes mellitus. It leads to increased mortality risk, decreased medication compliance. So if you look at medications, what are the major medications that are having issues between the first generation and the second generation antipsychotics? First generation is much safer. But if you look at the second generation, clozapine, olanzapine, in that order, quetiapine, risperidone cause a lot of impaired glucose tolerance, induced insulin resistance, might lead to diabetic ketoacidosis. So some drugs like aripiprazole, amisulpride are much safer, have better glycemic control, and if somebody can tolerate, first generation are better in terms of a haloperidol, in terms of a trifluperazine. So clozapine, olanzapine, quetiapine, please think before you start. Risperidone, aripiprazole, amisulpride, iloperidone, a little better drugs when it comes to somebody suffering from psychosis or schizophrenia with comorbid diabetes. So again, depression as a risk factor for type 2 diabetes. Madam has described it. I won't be talking about that. So one of the mechanisms or the what potential mediators of cognitive impairment in type 2 diabetes mellitus, it might be genetic, it might be because of macrovascular disorders, it might be due to hypertension, amyloid deposition, it might be due to hyperinsulinemia, it might be some because of drug therapy which we give, it might be because of recurrent hypoglycemia, it might be because of inflammatory mediators, and there might be some common things between diabetes and dementia, and it might also be due to depression, advanced glycation end products, acute hyperglycemia, HPA axis dysregulation, dyslipidemia, cerebral microvascular diseases. So everything is intertwined, and you have to take care of both. It's not just that you have to take care of diabetes and not take care about the cognition. So again, these are the mechanisms that may link diabetes and dementia. In terms of infarcts, ischemia. This is potential role of insulin in pathogenesis of diabetes. Again, aging leads to decreased insulin, decreased insulin receptors, decreased insulin degrading enzymes. So a lot of issues in terms of hypertension, dyslipidemia, hyperglycemia, hyperinsulinemia, prothrombotic state, pro-inflammatory states. So there are a lot of links between both. So coming to cognitive impairment affects management of diabetes and treatment-related complications. So what happens if somebody is having depression or having cognitive impairment? There is less involvement on diabetes self-care and monitoring. Very important. Increased likelihood of severe hypoglycemia, which I was talking about. Increased risk of major cardiovascular events. Increased risk of injurious falls. If somebody is having hypoglycemia, somebody is not on medications, he might be having problems in balance. So those are the ways which diabetes is affected by cognitive impairment and depression. So we've discussed about a lot of cognitive trajectories in type 2 diabetes mellitus. So the major independent longitudinal predictors of dementia, if you look at cognitive impairment leading to dementia, the older the age, the higher the chances. The most important risk factor for dementia is older age. The diabetes duration is very important. If the length of diabetes or the time period of diabetes is maybe 5 years, 10 years, more than that, the chances of patient ending up with dementia, it increases. The history of peripheral artery disease, exercise, it is protective. If somebody does not do exercise, the chances of dementia and all increases. So for Alzheimer's disease, diabetes duration was an independent predictor in addition to age and diastolic blood pressure. If you look at dementia and if you look at Alzheimer's dementia, diabetes duration was an independent predictor in addition to age and diastolic. Now, this is a mini cognitive screen which we do to screen for cognitive impairment in people with diabetes. So how do we achieve the best clinical practice? So in dementia care setting, step one, symptom awareness and active screening is very important. Then you do the symptom elevation and complication screen. Again, that's a screening that is done. Then you do risk minimization in terms of prevent complications that will reduce quality of life, like C for the eyes, C for the feet, reduce falls and hypoglycemia risks, medicine review if somebody is on anti-cognitive drugs and diabetes. So you consult the diabetes team if something can be changed, promote good nutrition, and diabetic care setting, what do you do? Awareness and screening for dementia is done, manage cognitive deficit, and minimize therapy risk. So avoid overly intensive management, use therapies that reduce risk of hypoglycemia. So sometimes we go overboard just because we have a degree, we think we know a lot of things. We tend to be over aggressive in our treatment. So let us be little more restrained, let us be little more you know hold up. Coming to diabetes and depression, a very very important issue which madam had been discussing in length. So individuals with diabetes have a twofold increased risk for depression, affecting approximately 1 in every 5 diabetic patients. That's a huge number. In people with diabetes, the prevalence of clinical relevant depressive symptoms is 31%, and that of major depression is 11%. People with depressive disorders have a 65% increased risk of developing diabetes. While depression affects maybe 3 or 5% of the population at any given time, the rate with diabetes is between 15 to 20%. That means it's more than 3 to 4 times. Depression is under-recognized in patients with diabetes, and when they coexist, one may worsen the other. So it is one pulling the other down and the other pulling the other down. So it's just a negative cycle which somebody falls into if somebody has both the things. So negative feelings, what happens? Actually, negative feelings about weight, shape, and body, decreased diabetic self-care, high blood sugars, depression, anxiety, very, very common. So, if you look at people with depression, without depression, the ambulatory visits are more, emergency department visits are more, inpatient hospital stay is more, prescription medications filled is much more when in diabetic patients with depression, and without depression, it is less. So, significant differences are found between only diabetes and diabetes with depression. So, depression and diabetes complications, a prospective association has been documented between prior depressive symptoms and the onset of coronary artery disease in people with diabetes. Depression and onset of retinopathy in children with diabetes has been found. So, a lot of complications associated with depression when it is associated with diabetes. Depression reduces physical activity, which increases the risk for obesity and consequently for type 2 diabetes. Depression is associated with poor diabetic self-care, include oral medication taking, dietary modification, exercising, and monitoring of blood glucose, very important factors. Emotional problems related to diabetes may lead to the development of depression. Somebody may take, like when I was diagnosed with hypertension, I was in depression for maybe 1.5 to 2 months when I thought, why me? So when somebody is having diabetes, he has to make a lot of changes in his lifestyle. If somebody is have to take insulin, he has to take care of food. He has to take care of where he eats his food, what he eats, how he eats, how many times he eats, carrying, his 2 chocolates in his pocket. Sometimes he might have hypoglycemia, sometimes he might have hyperglycemia, repeated testing, and sometimes people, cannot control their blood sugar even with a lot of medications. That leads to a lot of emotional turmoil. So the depression diabetes link, it's not just the emotional links, there's some biological factors, because depression is a phenotype for a range of stress related disorders which lead to an activation of the hypothalamic pituitary adrenal axis. Metabolic programming at the genetic level and undernutrition in utero and childhood may predispose to both diabetes and depression. So if there is, you know undernutrition also, it leads to diabetes and depression. So why is diabetes depressogenic? So it includes biochemical changes, hypercortisolemia, leptin activity in the limbic system, altered glucose transportation, including pro-inflammatory cytokines, and a lot of things associated with treatment, stress, sedentary lifestyle. Yeah. So coming to practical problems arising from depression, diabetes, comorbidity. So if they overlap, or sometimes depression symptoms mimic diabetes symptoms. So patient and clinician may be unaware of depression and may primarily attribute change status to worsening diabetes self-care. Depression may be associated with onset or amplification of physical symptoms, like Madam was talking about somatic symptoms. Patient may not sense he or she is fully understood or supported by his or her clinician during healthcare visits, when physical or lab results do not correspond to subjective complaints. Patient might be complaining, having a lot of subjective complaints, but the lab results or whatever, examination does not corroborate the complaints of the patient. The patient might be having depression and somatic symptoms, which we cannot get in a lab investigation. Depression is commonly associated with difficulties with diabetes self-management and treatment adherence. So patient may feel resigned about the ability to make changes. I know what I'm supposed to do and what I'm not supposed to do, but I still do the wrong things and I don't know why. So it's a sense of hopelessness and helplessness by the patient, which is not the right thing. Clinician may feel discouraged about the ability of the patient to make relevant changes in his or her cure. When we see a patient who is following everything, we feel much more inclined. We are much more involved in the treatment in comparison to a patient who does not listen to what we tell, who misses on follow-ups, who does not take medications, not understanding that a depression or anxiety might be the cause of for which why the patient is behaving like that. Individuals with depression may attempt to regulate emotions with food or substances. They may eat more. Stresses that interfere with self-management strategies and worsen diabetes status may also precipitate or exacerbate depression. So a lot of association between depression and diabetes. So what are the outcomes? Greater risk for heart disease, higher body mass indexes, hyperglycemia, worse diabetes self-care, reflected by a worse adherence to diet and exercise activity, which finally leads to increased mortality and morbidity. So depression can influence physical outcomes such as recovery from myocardial infarction, survival with malignancy, propensity to infection. Synergistic interaction between diabetes and depression result in decreased metabolic control, higher incidence of micro and macroangiopathic diabetic late complications, and decreased quality of life. So what do we do? So if you look at the signs which might make you feel that or make you think that somebody is might be having depression is depressed mood. Somebody is telling that I'm not feeling well, I'm not feeling good, I'm not feeling normal, I'm not feeling happy, decreased pleasure in normal activities, be it singing, be it dancing, be it studying, be it eating, be it playing, be it watching a web series, difficulty sleeping or increased need to sleep. I see a few of the people with depression, they are always sleepy, and some of the patients don't feel like sleeping. There is weight loss, or there might be weight gain. There's feeling of guilt or worthlessness. There's low energy level. There's difficulty making decisions or concentrating, and suicidal thoughts. So how do we do? So we first of all we look at how to manage depression. So how do we do? We increase the self-management. So explore loss of control of disease self-management. We have to understand the bidirectional link, how it overlaps, how it mimics diabetic symptoms, how depression amplifies the medical symptoms of diabetes. We break down tasks in self-management of diabetes, depression, or other illness, and help the patient to prioritize order of importance of specific tasks. We support the patient, we break down the problems, and then we consider medications. So if you look at medications, which are the most safest medications, any most of the antidepressants generally do not cause weight gains, but then we have to think about certain antidepressants which have a higher chance and some antidepressants which do not have a higher chance of increasing the weight. Among all the antidepressants, SSRIs are the safest drugs. Among the SSRIs, if you look at acetalopram, if you look at SSRIs, acetalopram are the safest drugs to give. You can give anytime, any patient. There's a broad spectrum antidepressant. But if somebody is having anxiety, a lot of anxiety associated with diabetes, we can give a paroxetine. Fluvoxamine is a SSRI which might cause weight gain, and that might have cause insulin resistance or might hamper the diabetic treatment. So let us be careful when we are prescribing a fluvoxamine. Mirtazapine is another drug. It's a NASA which causes weight gain. So that is one drug which can be avoided in people with diabetes. Bupropion is a weight neutral antidepressant. Vortioxetine is another drug that does not cause weight gain. So these are the drugs which we might consider. When it comes to tricyclic antidepressants, if you look at amitriptyline, if you look at dosilupin, these are drugs which are good for neuropathy. They're good for somatic symptoms. But if you look at diabetes has its list of the chances of a myocardial infarction. They might be having heart issues, cardiac issues. So TCAs, if possible, if somebody is little in the geriatric population, maybe 55, 60 plus, having blood pressure issues, better to avoid TCAs. So best is SSRIs or SNRI. SNRI I use a lot of desvenlafaxine when it comes to diabetes because they don't cause a lot of weight gain. They're good for anxiety. They're good for depression. Maybe SNRIs, desvenlafaxine, 4 to 5 millimeter of mercury of blood pressure they might increase. Now, another important complication of diabetes and depression is sexual dysfunction. Very important because most of the times we look at glycemic control, we look at the mood, but don't look at one of the primary important issues in a patient, that is sexual functioning. Sexual functioning is very important. You give anti-diabetic drugs, I give antidepressants, and finally we don't think of the person as a person. We just think of him as a diabetic or as a depressed individual or an anxious individual. We don't look at Mr. X as having 10 domains also. And that is where we as a team have to work in tandem. So use bupropion. Bupropion is very good drug, but the major issue with bupropion is it causes seizures. If you go above 300 to 450 milligram, the chances, the risk factors of having a seizure is much more. But bupropion in certain studies has shown to have better function in terms of sexual functioning. Vortioxetine is a new drug. It's a little expensive, but if you look at people having sexual dysfunction, vortioxetine is one drug which we can use. If somebody is having significant neuropathy, choose bupropion, venlafaxine, or duloxetine. Duloxetine is very good in old age people who are having urinary symptoms, incontinence. Use this duloxetine. It takes care of the pain. It takes care of the depression. It takes care of the urinary incontinence. So with one drug, you can look at 3 or 4 things. So good diet, sleep, exercise, avoidance of stress. So antipsychotics again, syndrome, TCS, valproic acid, and lithium are associated with metabolic syndromes. Increased risk of diabetic ketoacidosis with clozapine and olanzapine, so be careful. Also quetiapine. Antipsychotic induced metabolic changes are proportional to weight gain. Clozapine, during the first year of treatment, I have seen patients gaining 12 to 15 kilos. Quetiapine, 5 to 8 kilos. Olanzapine, 5 to 8 kilos. Risperidone is a little better, maybe 2 to 3 kilos. Aripiprazole, ziprasidone, amisulpride. Ziprasidone we don't use a lot because it causes a lot of QTC prolongation. So generally we avoid ziprasidone, even though it's a good drug, it's weight neutral. And amisulpride, aripiprazole are good drugs, or use first generation antipsychotics if the patient can tolerate first generation. Depression treatment improves insulin. So, so if you treat depression, index of insulin sensitivity increases, there is the BMI decreases, HB1AC and improved self-care with bupropion is seen, and reduced depression severity predicted, HbA1c in both, uh, better HbA1c control in both acute and maintenance phase with bupropion treatment. So bupropion treatment is a little better. So choice of antidepressants, we should look at an antidepressant which should have no influence on body weight, no interactions with the numerous medications that the patient is likely to be taking, should not be hepatotoxic, should not produce cardiovascular blood pressure effects. It should have minimal sedation or the patient might have falls, minimal or no sexual dysfunction. So MAOs might cause hypoglycemia, orthostasis, dietary restrictions. TCAs might cause weight gain, cardiac conduction delays. SSRIs improves the glucose control. They reduce the insulin requirement among the type 2 diabetes. So degree of risk of diabetes with antipsychotic, clozapine, olanzapine, quetiapine highest. Then is risperidone, phenothiazines. Low is haloperidol. Minimal is aripiprazole, amisulpride, ziprasidone, acinapine, lurazidone. So coming to drug-drug interactions, fluoxetine, fluoxamine combination inhibition, piglottazine, ripaglidine, and etiglidine, they do the lot of interactions. We have to be very careful. Now, coming to certain issues for 2 minutes, I like to speak on certain issues. Like if you look at delirium, delirium is another condition which we see a lot in our ICU or general hospital psychiatry consultations. That is one thing which we have to take care of. Substance use disorders. Again, 50% of diabetes are known to take alcohol. Alcohol creates a lot of issue. If you look at alcohol, if you take a low dose of alcohol, some texts talk about having protective effect, but I don't see that. So chances of your insulin, tolerance increases. You having poorer diabetic control. You having more accidents. You being more depressed, more anxious with alcohol use. So alcohol is one thing which we have to take care of. Again, alcohol, the treatment of alcohol use or abuse or dependence, and anti-diabetic treatment, a lot of interactions which we have to be very careful about. Again, eating disorders are common. When somebody is having eating disorder and you don't treat the patient properly, and then you have poorer control of diabetes. That is one issue. We have to look at smoking. Very important thing. Smoking no for all diabetic, because it really causes issues in terms of the treatment, the way nicotine. And if somebody is smoking and is having diabetes, some studies talk about using metformin as anti-diabetic drug. It causes less amount of withdrawal from smoking. So that's one drug that is very, very good. But then you have to look at metformin and alcohol. It causes a lot of issues. So metformin for smoking is good. Metformin for alcohol, when it is associated with diabetes, is not to be used. So a lot of issues are there, a lot of things are there. I think once we are aware that yes, this can happen or this might not happen, we will be more careful. A combined approach is very, very important, because at the end of the day, we are looking at the patient's well-being. We are looking at how good we can get out of the treatment outcome for the patient. Thank you so much.
Oh, I think we should take some questions now. If anybody have questions.
Yes, ma'am. Dr. Roy wants to know that should a patient must have treatment of both diabetes and depression together?
You are not audible.
I'm using currently PowerPoint, sir. Microsoft PowerPoint.
So somebody is on
Yeah,
medications for
इतना
diabetes
laptop.
and depression. उसके बाद
Can questions be written in the chat box so that we can read and then answer?
I think the viewers have a different link. So I think you should have sent a separate link for question and answers, which we don't have.
Okay.
Somebody can copy
Dr.
and paste the
Amrit,
questions.
can you listen to me, sir?
Yeah, now I can listen to you.
Okay, I'm sorry, there was some issue from my end, sir. There's a question from Dr. Sharbani Roy. It is like, should a patient must have the treatment of both diabetes and depression together? So this is the first question.
So if somebody is diabetic, has diabetes, Dr. Ankita will treat. If somebody has depression, I will treat. If somebody is having diabetes and depression, we both can treat and we should treat. Both are things which need attention of the clinician, and it is as important. Diabetes is as important in depression, or maybe depression is as important in diabetes. So both need to be treated. If somebody is having a syndromal diagnosis, you need to treat them.
Sir, there is one more question from Dr. Suhas Kumar from West Bengal. Choice of anti-diabetic drug in obese diabetic with dementia. What should be the choice of diabetes drug in obese diabetic with dementia?
Okay. So first we have to choose the target HbA1c level and then have to titrate the drugs accordingly. So if somebody is obese, diabetic with dementia, advanced stage of dementia with the life expectancy with less life expectancy and cognitive decline is high, then HbA1c target would be a little relaxed, like it may be 8 to 9%. Then first choice would be metformin. Metformin is good for both obese individual in metabolic syndrome, and if HbA1c target is achieved, then it's fine. If it is not achieved, then other drugs could be DPP-4 inhibitors. If obesity is very high, then GLP-1 analog could be a good choice in obese people. But at the same time, if glycemic targets are not achieved, HbA1c is very high, then we have to shift to other classes of drugs as well. But for weight loss, for metabolic syndromes, metformin, DPP-4 inhibitors, GLP-1, SGLT2 inhibitors, they are our preferred drugs in obese people. And for dementia, Dr. Amrit would be.
So we are talking about a phenomenon known as type 3 diabetes mellitus, no, where there is
Yes.
association with dementia with. So basing on the, if it is early onset, early stage of dementia, we can look at donepezil as a drug. If it is little moderate to severe dementia, we can look at memantine. I think I generally prefer a combination of donepezil with memantine, and we can go with galantamine, which is a little expensive. So what madam talked about metformin, I have read about metformin being is a better drug when it is dementia and diabetes association. So I think that's fair enough.
Yeah.
you, ma'am. There's one more question from Dr. Subhashri Majumdar from Odisha. And the question is, as a diabetologist, what are the steps to diagnose depression if I suspect depression in my diabetes patient? Uh, so that is the question, sir.
I'll take the question, madam, or
Yeah,
you'll take
yeah,
it.
yeah. Because he's
I think I
particularly
should take
asking
it.
about depression. Yeah,
So I should take it.
yeah.
So it, diagnosis of depression in a patient with diabetes, in a patient of hypertension, in a patient of are almost similar. Like there'll be more of somatic symptoms. There might be more of somatic symptoms, but the core symptoms will be the mood. You know, the mood will be little low or irritable or below what it has to be. Patient may be complaining of being sad, not being happy, or being on the edge, over anxious about small things, losing interest in pleasurable activities. Like somebody wants to speak, somebody wants to dance, somebody wants to dress up well, somebody wants to eat, somebody wants to go out. Now he or she is not getting the same pleasure, or he or she not having the same interest. Now easily getting tired. Again, diabetes people get easily tired. In thyroid, hypothyroidism people might get easily tired. Depression, in the clinical symptom of depression also, the patient gets easily tired. Like somebody was working from morning 9 to evening 5 o'clock, he was fine enough. But now from morning 9 o'clock, by 11:30, somebody gets tired easily. Again, that's a sign that somebody might be having depression. Now, loss of interest. Patient is not able to concentrate, not able to focus. He's not able to remember things. He's feeling guilty. Something happens, he thinks that I am responsible for all these things. You know, then sleep reduces. It might also increase appetite. Again, one of the very important issues with which diabetes and depression are very, very strongly correlated is about the appetite. If you look at the educated mass, the people, when they get depressed, they tend to eat a lot. They tend to they tend to binge on chocolates. They tend to binge on sweets because that releases a little bit of you know serotonin surge. That there's a serotonin surge because of which they feel a little good. So what happens is they binge on a lot of things, and what will the endocrinologist think, that I'm giving everything, but this patient is going on binging and so that is one important aspect. So appetite, sexual functioning, sleep, very important biological factors. Along with that, a sense of worthlessness. I'm of no use. A sense of helplessness. I have nobody to look after me. Now I'm diabetic and nobody is looking at me. There's a lot of stigma attached to diabetes even today. I've seen couples who are serving food properly to the spouse because somebody is diabetes. So a lot of stigma also occurs with diabetes. And the third most important thing is when somebody feels that there is no hope. I am taking medications, my blood sugar is not level, my glycosylated hemoglobin is coming to 9, my endocrinologist is shouting at me, my parents, my spouse is shouting at me, I'm trying my best but I'm not able to maintain. And then there is a feeling of hopelessness. And once somebody is hopeless, negative thoughts come to the mind in terms of ending my life. Now I start. Now my endocrinologist tells me that you're not able to maintain your diabetic control. You might lose your kidney. In a fit of it is for the concern for the patient. But we sometimes speak out that you might lose your kidney. You might have a stroke. Okay, I'm going to lose my kidney. Then why should I live? So somewhere the death thoughts might come, and somebody might do something. Somebody might cope in terms of taking alcohol. So if these are the signs, you should look at the psychomotor activity. Somebody has become slow. Somebody's speech has reduced. These are the basic signs of depression, and then maybe you can think of referring somebody or starting somebody on a medication and then referring. I would always prefer somebody to start a medication and then refer to us. Otherwise, the patient thinks that yes, मैं आया था diabetes control के लिए and they've sent me to a psychiatrist. So it's always better that you can start them on some medication which is little safe and then refer to a psychiatrist. That helps the patient a lot.
Thank you, Dr. Amrit, for the explanation. Now, I think there's no more question in the question panel. Only there are in the chat. We are getting some feedbacks like it was excellent presentation, and they are thanking both the presentation for the presenter. And there's no more question as of now. So, over to you, sir.
Okay.
Ma'am and sir, with your permission, can we conclude the sessions?
Yeah, sure.
Thank you so much. Thank you.
Thank you.
Thank you, Dr. Amrit and Dr. Ankita. On behalf of Lupin Sinox, I would like to thank both of you for your insightful and educative talk. Our attendees really enjoy the session, and we also thank for attendees for sparing the time and attending the cross connect.
Thank you.
Thank you, sir.
Thank you, Dr. Ankita. Thank you, Dr. Thank you,
Thank you.
Lupin.
Yeah, yeah. Most welcome.